let me start, and I'm really looking forward to someone raising their hand this morning. But, Michael, first, if I was a CEO sitting in this room, I'm thinking you've just explained how much money can be made in the way of integrating pharmaceutical services or pharmacists more so into the hospital setting. I get the impression you think that CEOs or administrators don't really understand medicine or what pharmacists can offer. Is that fair?
Look, I think what I mean is that I think there's a lot of downstream effects of not getting the medicines right that are hidden, and that whether that be delays in care or complications that actually cost a lot of money. So, for example, people will know that there's antimicrobial stewardship programs available. People are looking at antimicrobials. We know that one of the biggest risks in hospitals is anticoagulation, either not giving an appropriate anticoagulation and people clot, or giving them too much anticoagulation where they bleed. Now that has significant impacts. The same thing goes for analgesia. We know poorly controlled pain is a major issue in hospitals, and it delays discharge. It delays, it's poor care and it delays. But how many people are actually funding programs to look at anticoagulation and to look at analgesia? So, for example, we've got now, besides having an antimicrobial stewardship program, we're having an analgesic stewardship program and an anticoagulation stewardship program. So the hospital is going to look at how we use analgesics and how we use anticoagulation. Now, a lot of people may not even focus on that, but poor care associated with anticoagulation costs a lot of money. Results in delays of care, results in readmissions, it results in deaths. And the same goes around analgesia. So all I'm suggesting is that what we should be doing is not looking at how much it costs to dispense a packet of endone or how quick the script gets up on the ward or those sort of aspects, which are important. But what is important is that we look at how we use medicines, and there are significant downstream costs associated with poor care associated with medications, and we should be investing more in that. That includes the CEOs, but also includes private insurers and everyone else.
Are pharmacists represented on managerial, on executive committees within the hospital?
Look, I think it depends.
More broadly than your own, I guess?
I think it depends where you work. I mean, I'm fortunate at the Alfred, I sit on the exec, and that's all right. But I think in some instances you'll have pharmacy services under corporate services managed downstream, and therefore I think can be a major barrier. But certainly it's variable between different places.
Just make a comment on that. I spent about 10 years working in the United Kingdom as a director of pharmacy for a large foundation trust. Going back in the early 2000s, a mandate came out from the Department of Health which essentially required chief pharmacists to report directly to a board director. And that was a major step forward, because it meant that pharmacists are actually available to contribute to those discussions around service delivery and provide that kind of intel around how the system can actually save money. I don't think in Australia we've really got there. We've got different reporting mechanisms in different sectors, but also even the public system, it's not uniform. So in England, that was a major step forward in how pharmacy was able to set up those systems uniformly and integrate into the trust developments.
And you believed it made a material difference?
Massively, yeah, massively. Because suddenly we had to send a medicines management report to board every year with a 5-year action plan. And suddenly, from pharmacy being an allied health service, it became really a core part of what the organisation was setting out to deliver. And that was in response to a range of safety initiatives coming out of the UK at the time. I mean, you may all recall the shipment inquiry and that massive issue around controlled drugs. There were some major trigger factors which resulted in those changes occurring in the National Health Service.
So that shows how perhaps administrators, CEOs, hospitals could use pharmacists more, or the expertise you offer. But is there, how can I say this? Do pharmacists understand business strategy sufficiently to see that what they offer in the wider context, or should business strategy be part of what they learn?
I think it depends on the pharmacist, as in most things. I mean, a lot of pharmacists working at that level hold postgraduate business qualifications. I would argue that if you are in those positions, then you should understand that as part of the job requirement.
Look, I think it's I think pharmacists don't understand how hospitals work primarily. They understand how pharmacy works primarily, and the further that those services are from the hospital, or the further they are not integrated within the decision-making processes within the hospitals, the more disengaged they are. So, for example, if we're sitting around a meeting tomorrow where we've got bed block, for instance, and we know that there's problems around that, and you're part of that, then you're part of working out how to get that solution. And I think one of the challenges we've had is that pharmacy has been divorced a bit from some of that, how the hospital works and what some of those drivers are. And as a consequence of that, then it's harder to understand where they can contribute or where they may have to get out of the way.
So what is one concrete step that a CEO or a senior administrator in a private hospital could take post this conference that you think would result in a monetary and material difference?
Look, I think the main thing is that the CEO or anyone who's having a relationship with a pharmacy service understand it's not about the dispensing. Dispensing is getting the meds there and all that sort of stuff. That's only that's the tip of the iceberg about what the contributions can be. So I think that's the first thing. I think the second thing is that the pharmacy services have to make sure and continue, no doubt they do, and we continue to do, is to try and understand the services, where they fit into the services getting provided more broadly. So they understand the drivers of the hospital or whatever that may be. And so I would like to see the people actually helping with that engagement, both from the pharmacists trying to get more engaged and also from the services and enabling that to happen.
Russell, did you want to add there at all?
I guess one thing also, when new services are being commissioned, I mean, that's an ideal time to start looking at innovative models of service. And I would suggest that, getting in touch with your pharmacy manager or your most senior person that's a pharmacist to start having those discussions sooner rather than later. Generally, once that service has been commissioned and it's set up and someone comes and says, oh, look, new ward's opening next week, we've got 30 beds, can you service it? It doesn't really give you the chance or the scope to do things differently. I think also, the pharmacist's got a responsibility also to make sure they're across some of these innovative ways of working. And, how do we collaborate further with the public system and what can we learn out of the work Michael's doing at the Alfred that can translate into private practice, which is going to add value and make a compelling business case for that investment to actually happen.
You just mentioned the learn word. What makes a pharmacy not work well in your view?
I think when a pharmacy works well, it's almost invisible. I think when it starts to break down, it very quickly becomes obvious. So I think things like when services are added and they're not resourced, when you get technology problems, when the skill sets that are required to deliver services change and your staff don't change, things can start to break down. So it's important to be across those things to make sure that the services continue to deliver what they're setting out to do.
We haven't talked about e-health and how digital medicine, how that whole area is going to impact on pharmacy. Would you both just talk about that briefly?
Yeah, look, for example, the Alfred, we've selected Cerner as our provider, and we're going to have a paperless system towards the end of the year, and end of next year, and I've got the pleasure of supposedly being responsible for that. The challenge I think we have is that people think that you put in an electronic system, therefore you don't have to have someone actually going and seeing a patient. So what you do is, the chart at the end of the bed or wherever it may be is a reason a pharmacist may actually go to a ward. Get rid of that. The pharmacists can all stay downstairs or be remote. And I think these systems have some substantial advantages, but the systems only have advantages if they actually make the decision better for the clinician at the end of the bed when they're making a decision. So what's most important around these systems is decision support. What's the information you provide the clinicians? Now, most places, and I think the challenge we have, is that most people will implement a system and they won't actually think about decision support. They think, let's get an electronic system, it's all really good, put the pharmacists in the basement, they don't have to go up to the wards, that's going to save some money, get rid of some pharmacists. What's most important for the clinician, and that be whether it be the nurse or a nurse practitioner or the doctor or an anaesthetist or whatever, is having information provided to them when they're making the clinical decision. And that's where the advantage of these systems will have. And what we need to be doing is we need to be investing in decision support for these systems. And I suppose at the moment, we do that from some pharmacies will do that and get involved. But how many systems people are implementing these electronic systems and putting hardly anything into the decision support that's going to be the thing that's going to help the nurse at the end of the bed select the right drug, or the doctor at the end of the bed, or in his car, or wherever he may be, making that right decision. So I think they have advantages, but we will not get the benefits of these systems unless we put in the systems to support them, and that is around decision support, and that is where we aid people to make the right judgment call. And I think there's a risk here that we don't do that, and we just implement simple, uncomplicated systems, we don't get major benefits.
I agree with what Michael's just said, but I probably also want to add maybe a patient perspective. I guess these systems do give us an opportunity to really open up what information patients can access. We're doing some work at the moment in our group around providing patients and GPs with full records of drugs administered in hospital and information around that. We do frequently get issues arising and patients aren't informed, etc. And I think that technology is going to give us a major opportunity to how we actually educate patients and provide them information around medicines, which is what they're actually asking for also.
You were talking, Russell, about cultural change or the difference in culture between private and public. And pharmacists strike me as fairly conservative by nature. Is that a hamper to innovation? Does that make that journey to change more difficult?
I think it definitely does. I think it does depend a bit on where you're working also and the actual culture of innovation or change that's present. I can give an example, like say my wife's a pharmacist in a major public hospital. If she wants to do an order, it's got to go up through 3 different committees, back down again, and so there's a lag time to be able to make that decision to do an audit, where in the private system we can decide tomorrow and have it done within a week. So we seem to be far more agile and far more quicker at doing things. I do think pharmacists, though, they are risk averse. I think it is a challenge for us in how we try and skill up people within our profession to try and innovate and drive change.
Did you want to add there, Michael?
Yeah, look, I think it's changing though. I think, so for instance, where I work, 80% of the pharmacists have postgraduate qualifications. 10% of our clinical people are actually doing PhDs. We're about to implement residency programs around Australia in 2017 for pharmacists. So when you register as a pharmacist, you're going to go into residency programs. So I think with that and with their ability to, I suppose, contribute more, I think there's more of a change. I think that there will always be a subset of any profession that will be quite comfortable with the status quo. They're happy to do what they've done because maybe that's why they went into it. But I think there's certainly an underused capacity here of experienced health professionals with fantastic education that we're not utilising in the right way. And I think the challenge we have is that there's problems with medication use, and that hurts the bottom line, and that hurts patient care, and a lot of the time it's unidentified, and therefore it's not necessarily obvious. And
why isn't it identified, can I ask?
Well, there's lots of things happening. If a patient comes in for a surgical procedure and they've got to have a skin flap or something done, the fact that their pains are poorly controlled may be a delay in their admission by 12 hours or 14 hours, or the fact that they're smoking prior to them coming in, and if someone hasn't seen them at pre-admission and told them to stop smoking so that helps their wound repair. These are things that may add on an hour here or 2 hours here or 4 hours here. They add up, and they're not seen because they're not identified, and there aren't people necessarily shining the light on them. And I think that's where pharmacy's got to be a little bit more about shining the light on where improvements can be made and advocating for those more strongly.
Early election, 5 of the 6 crossbenchers have said no to Malcolm Turnbull's demand yesterday, which suggests a July 2 federal election. Are there any crucial reviews or reports or decisions you are waiting on in the pharmacy area ahead of that?
Well, there's a major review under the community pharmacy agreement about what happens. There's been one that's been signed for the last 5 years, but there's 2 years where it's sort of part funded, and the decision is what's going to happen around remuneration of pharmacy. So that review's on a current way, and there's consultations happening, and we've been involved in that. So I think that's going to be a major change, if there are major changes, depending on the political will. In 3 years' time, or the next agreement, the question around location rules will come up about where you can have a pharmacy, and at the moment it's very tight in regards to where you can open a new pharmacy, and can a private hospital with not a lot of beds open a community pharmacy is a lot more difficult. So I think there are some significant things that are going to change going forward in this space.
Anything you want to add there, Russell?
No, but I guess one of the major issues that this remuneration panel's looking at is whether we should decouple a dispensing fee from product. So instead of pharmacy getting its revenue through the dispensing process, is moving to a fee-for-service based model where it's untangled, which is far more clear around value add for the consumer. Yeah. And that's the big question. So in some ways, that review is reporting in about 5 years' time, the end of this current agreement, and that may be when we see a complete change in the sea of how pharmacy is funded by the Commonwealth Government.
Yeah. Okay, ladies and gentlemen, that draws to a close this session. Could you please put your hands together for Professor Michael Dooley and Russell Hill?